Good morning. I think we'll get started. As you know, this is probably the first time we've had grand rounds here at Children's Hospital, the Department of Surgery grand rounds. So there'll probably be some stragglers coming in and out. The other thing I wanted to remind you is to register for your attendance with the QR code. And with that, I'll launch into a little description of who Dr. Lilly was, and then David will introduce our speaker. So John Russell Lilly, whom this lectureship is named after, was a pediatric surgeon here in Denver for about 20 years. He started in Wisconsin, did his undergrad and medical school education there, and then did an internship, interestingly, in Hawaii. I wish I could do an internship in Hawaii. And then completed his surgery training at UCSF. Following that, went to Great Ormond Street, a prestigious organization in London, to do a thoracic fellowship, and following that, became the first pediatric surgery fellow at that time DC Children's Hospital in Washington DC under Judd Randolph, one of the giants of our specialty. Stayed on as faculty and was joined by a couple of other important persons in pediatric surgery, Peter Altman and Kathy Anderson, who subsequently became, I think, president of the ACS. And further went on to do another fellowship in transplantation here at the University of Colorado with Dr. Starzl. This is like late 60s, 69, 70. Transplantation was in its earliest beginnings. As an aside, some of you may know that the first liver transplant was done in a 3-year-old with biliary atresia in 1963, here by Dr. Starzl. But at that time, patients weren't doing that well. Immunosuppression was in its infancy. The technical details of the operation were still being worked out. And he went back to work in DC, and then was recruited back in 1975. This slide is slightly in error. 75 by Dr. Starzl to the University of Colorado, and became the division head, and retained that title until 1995 when he passed. Along the way, Dr. Lilly, I think for those of you in the audience that know him, would agree, really unique individual, clever, but a consummate teacher. He used to intersperse slides of fairy tales or cartoon characters in his talks, not only to quiz us about something a little bit different from medicine, but to get us into the mindset of children, and was well known for his educational pursuits. Also a great scientist, and studied the problems of biliary atresia and other hepatobiliary problems, choledochal cysts and others, and wrote extensively about it. And actually, he and Peter Altman introduced the Kasai operation to North America, which prior to that, most surgeons said it doesn't work, it's a different disease in patients from the Far East, and didn't believe in the operation. He and Altman showed that it could work, and really made a career out of that type of patient. In 1991, the Children's Hospital and the University Pediatric programs merged, which allowed the clinical and caseload from the Children's Hospital with the academic structure of the University Hospital to be put together. He was the first surgeon in chief, and that also allowed us to start a training program, which he did, and exists to this day, some 20 to 30 trainees by this time. So we established on his untimely passing, established this lectureship to bring in some of the leaders in pediatric surgery, some of the giants in pediatric surgery. And if you look at the list of speakers, it really is a who's who in pediatric surgery. And today is no exception. I don't want to steal any of Dave's thunder, but Dr. Barksdale is recent past president of APSA, the American Pediatric Surgical Association, which is the pediatric surgery organization for the country, but I would submit probably also for the entire world, the biggest and the most prestigious. So I'll let David take over, but I hope that Dr. Lilly's legacy will live on and continue to bring in some of the best speakers in our specialty.
Thanks, Fritz. It's always good to have that firsthand knowledge Dr. Carr has. I overlapped with Dr. Lilly for 2-3 years as a junior resident here at the University of Colorado, going back a ways now, and was able to experience some of his fireside lectures and such, and so terrific experience. So as Dr. Carr mentioned, Dr. Edward Barksdale is our current Lilly visiting professor, and I'll give a brief background. He grew up in Lynchburg, Virginia, in a relatively turbulent and dynamic time in the 60s. We heard some about this last night at dinner, and I think some of these stories will show up in the talk he's going to be giving today as well. He did his undergraduate education at Yale University, graduated with honors, and was also an All-American athlete in fencing, which is tremendously interesting. And then went on to medical school at Harvard University, and then stayed in Boston at Massachusetts General Hospital. During his residency time there, spent time doing research with Dr. Patricia Donahoe, and was also the first African-American to serve as the chief of the West Surgery Service, which those people that have experienced Massachusetts General Hospital know that that's a very prestigious position there in terms of a super chief type of a position. He then went on to do pediatric surgery fellowship in Cincinnati. This was under Dr. Maury Ziegler, who was the chief and the program director there at the time. Of course, Maury ended up coming here to Children's Hospital Colorado as our surgeon in chief as well for a period of time. So some overlap with the program here in Colorado. And then took his first faculty position at the University of Pittsburgh at Children's Hospital from '94 up through 2007, and progressed up to a professor with tenure there. And I remember interviewing there as a fellowship position, and actually later than that as for a potential faculty position as well. And the chief there was Dr. Eugene Weiner, and he also had a partner, Dr. Henri Ford, who, as Fritz mentioned, there's a previous pediatric surgeon, Kathy Anderson, who ended up becoming president of the ACS, and Henri Ford was just announced as the incoming president of the ACS as well. So terrific faculty there at Pittsburgh at the time. And then became the first endowed chair and chief of pediatric surgery at Rainbow Babies and Children's Hospital at Case Western in Cleveland, starting in 2007, and became the surgeon in chief there in 2012. Dr. Barksdale is a member and leader of many prestigious surgical organizations, but as Fritz already mentioned, this last year was the president of our largest pediatric surgical organization, the American Pediatric Surgical Association. Gave the presidential address at the meeting this last May in San Diego, which many of us had the privilege of being there for, entitled Noblesse Oblige, Advocacy, Activism, and Leadership, and was a tremendous talk. And so we invited Dr. Barksdale here as our visiting Lilly professor. He has had a very busy year traveling around and giving talks, and we were talking about this last night, including a visit to the White House this last year too, which again might come up in some of his discussions. Dr. Barksdale's academic interests include the immunobiology of neuroblastoma, one of the more common malignancies we deal with in pediatric surgery, and has had a funded lab investigating this. Was one of the really initial surgeons, at least, investigating short bowel syndrome, and had developed the first interdisciplinary program there at Pittsburgh treating children with this problem, including small bowel transplant, which was really a novel treatment at the time. And more recently is involved with the impact of toxic stress and specifically youth violence on the health of children and communities. He is the co-founder of the Anti-Fragility Initiative at Rainbow Babies Hospital, which is a novel hospital-based, holistic, person-centered pediatric violence prevention program. It's funded through a greater than $2 million grant there, as well as by philanthropic funds. As I mentioned, a frequent lecturer on these clinical and social issues, currently works at the nexus of academia, clinical surgery, medical education, public health, and social justice. So we are honored to have Dr. Barksdale here today as our Lilly visiting lectureship.
Dr. Partridge, thank you very much. Dr. Schulich, Dr. Carr, and the rest of the faculty, thank you for an absolutely incredible dinner last night. Is there any way to take the notes off? I don't have notes, but anyway, it was a great dinner last night at North Italia. All my punchlines are on. I want to go to the beginning of the talk. Maybe this is the way that the angels are saying you got too many slides. Let's just go to the end of the talk. So that's beautiful. I just want to say thank you. As Dr. Partridge mentioned, I've been doing a boatload of travel, but there's something nice about waking up at a hotel and looking at the reflected sun off of the Rocky Mountains as a way of helping to make you calm. The hotel was nice, and so I understand very well this feeling of what is great about Colorado. And also such a beautiful children's hospital that you have here. And so I'm excited to be here and look forward to my time. I bring you greetings from my new hometown over the last 15 years of Cleveland, Ohio. This is beautiful downtown Cleveland. It's a city that does not get its due for its beauty. I'm at University Hospitals and at Rainbow Babies and Children's Hospital, where I do my work. Wow. How beautiful is Aurora, Colorado. But as we gather this morning on the ancestral homelands of the Cheyenne, the Ute, the Arapaho, and Lakota peoples, past and present, who not only inhabited this land, but were stewards of their own people in the land, I'd like to acknowledge their role in the history of this region and setting this up to be a place that contributes so greatly, not just to pediatric healthcare or American healthcare, but to the quality and nature of this great country that we have. And so it is these ancestral groups that really provide the foundation for the greatness of this hospital and this region. Likewise, we heard about John Lilly. I did not ever spend much time with him. And I took out my slide showing the Three Stooges, showing the Seven Dwarfs. Notoriously, you'd need to know all these things that were tangential to medicine, but it gave me an idea of his sense of humor, as well as his great ancestry within surgery with people I worked with, like Tom Starzl, a distant mentor, Judd Randolph. And the operation that he popularized that many of us do now has changed the face of patients with biliary atresia. As I came and as I prepared to talk to you about surgery education, which is what I want to do, I reflected on my own history as a surgery resident. Can anyone pick me out in that picture? I'm the one just to the left of Jerry Austin, the chairman of surgery, who passed away at 92 a few weeks ago. But this is a classic picture from the MGH taken every year in black and white on what's called the Bull French lawn. And I had an incredible surgical training program. And the surgical training program that I had is much like the program that many of us who were senior had, particularly those of us who were at Hopkins, who this is their hero, Dr. Schulich. And the philosophy that Dr. Schulich grew up in with many of us who were descendants of this tradition is that the hospital, the operating room, and the wards should be the laboratories. The laboratories are the highest order. And we know from experience that where this conception prevails, not only is the cause of higher education and medical science best served, but also the welfare of patients is best promoted. So I followed this. I worked at Biogen, which was a startup then that's blown up. I was a visiting scientist. I, until 15 years ago, was making cancer vaccines for the pediatric tumor neuroblastoma. I drank this Kool-Aid. But as I have evolved, 15 years ago, I made what I've called a transition from academic success to what I think is social significance. And I recognize that we as surgeons, whether we're members of the House of Surgery or the citizens of the village, we have an unbreakable contract with society. And so I'd like to talk to you this morning really quickly, a ton of slides, it's gonna make you dizzy, but I'd like to talk to you a little bit about this unbreakable contract that we have. And I think that we're at a very important time in medicine, surgery in our country, at which we are at a tipping point, and that we, as we design the next iteration of surgical education, that we think about broadening how we educate surgeons in training. These are my objectives, and you can see this, but in simple terms, I want to talk about the social determinants and their relevance to surgeons, not just pediatric surgeons. I'd also like to discuss some novel things that are going on in the country to promote this concept of socially responsible surgery. And like every surgeon, I want to tell you a little bit about my work. My father would say your job is where you get paid, your work is where you add value. And so I hope that I can talk about the work that is adding value to the Cleveland community and hopefully beyond. I have one disclosure. Wow. The last 2.5 years have been absolutely mind-blowing. Whether it's the virus, the financial markets, the racial reckoning that has occurred in this country, the so-called female gender recession, women leaving the marketplace, the subsequent great resignation, or the social divides that have occurred in our country, and the whole host of things from the threat of nuclear war to climate change that really have put us on the edge of understanding, where do we get our resilience? How do we change? How do we move forward? I would say that we're clearly at a tipping point in this country. Those of us who have worked with social disparities recognize that the pandemic also exposed the systemic inequities and the fragility of various populations in this country. You guys know this. This has been in the news. It's been at the American College of Surgeons, but there are significant disparities that exist. And I showed the last slide, we often don't know what disparity is until we see it. And it's sometimes hard to think that it really exists. And even for those of us who are surgeons, we are not immune. And it is important for us to broaden our horizons, broaden our thinking to think about how we can address this. So rapidly get through this. I'm not going to go into this detail. You guys read the same literature that I read. But whether it's race and ethnicity in the morbidity and mortality of malignancy, or whether it's socioeconomic status in these same areas, or whether it's gender identity, sexual preference, we have vast disparities that exist in subgroups and populations within this country. You guys know this, these are the social determinants of health. Much of our health outcomes, so when we think of health outcomes, we think of premature death, disability, and disease. Premature death, disability, and then disease. And in the city that I live in, Cleveland, I've added a fourth D, and that is despair, because despair drives a lot of poor health outcomes or poor health in our community. But these are the social determinants, the various categories that both the WHO and the CDC utilize. And the interesting thing that I find as we look and we go deeply in understanding the social determinants, something that I never would have thought about as a surgery resident, trying to remember the difference between Bassini and Cooper's ligament and Billroth 1 and Billroth 2, and whether Dr. Warshaw was going to do his anastomosis one way and whether Dr. Carter was going to do another. I recognize that all those nuances of how we do things clinically don't really make a big impact on the overall health outcomes. And in fact, that we don't or refuse to think about that can improve the health outcomes by, in 2002, 20 years ago, they felt it was 70%. It's now acknowledged to be in the realm of about 80%. So Cherry Creek North, where I stayed last night, the last 2 nights, incredible, beautiful. The first thing I wondered after living in Cleveland, was it safe to walk around at night? Well, I think a chipmunk or some kind of animal ran across in front of me, but it's really safe. In Cleveland, I'm worried about a lot of other things, 2 great cities. So you may not have to think about some of the things here in Aurora and in Cherry Creek that we think about in other urban places, but I challenge you to think about them. So what's going on in Colorado? So you can see the slides, and in summary, each of these slides suggests that disparities exist here in Colorado, and that there is an opportunity, not just for pediatricians, primary care, public health people, but I think of, forgive the chauvinism for those of you who are out there, I think that surgeons are incredibly well poised, not only to make the difference in the social determinants, but to lead in the hospital, in the community, and in the boardroom. But you see these numbers. And one of the things that we've noticed in Cleveland, which is a big component of poor health outcomes, are housing instability and food insecurity. In fact, the biggest driver of violence in the pediatric population in Cleveland and the young adult population is not drugs, it's food insecurity. And these, to me, are easily actionable things. And we have the data for that I'm not going to present today. But you can see that the wealthier you are and the more educated you are, that wealth equals health. So what type of framework? I talk about the role when I was at AXA this year, and what I've done nationally is that, much to my wife's chagrin, 16 years ago, I took 1/4 of my salary and I gave it to the Society of Black Academic Surgeons to establish this SBAS Leadership Institute. Since that time, over the 16 years, we have had 120 leaders emerge from this program in leadership to lead broadly. And some of them include people like Patricia Turner, who's now the director of the American College of Surgeons, Andrea Hayes Jordan, pediatric surgeon, who in 1 month went to be the second African-American woman department chair to dean of a medical school, and a whole host, Paris Butler, a whole host of people. But the important piece is I think that leadership development is so critical for us as we train surgeons. So a part of training advocacy is training people to see problems, to work with them with our hands as we do, and then to go to what I call the balcony or the penthouse to get a different view of how we can create solutions and change policies. But the central role of the surgeon, I think, rests within this schema that Megan Janeway, who was a surgery resident at Boston University Hospital, created and was published this year. And it allows us to effectively think and creatively think about how we impact change and our patients' ultimate outcome. And we all have the same ambition, right? Whether we're in the lab, as I've been, whether we're doing novel clinical programs such as we did when we built the short gut program in Pittsburgh that included intestinal transplantation, the first of its kind in the world. We have this opportunity to think of ourselves in many different ways that are beyond the traditional boundaries. I show this slide to show my best friend, Henry Ford, my protege, Jeff Upperman, and one of my friends. This is really to honor one of my close friends who we lost this year, Paul Farmer. I first met Paul in what's called minor surgery at the MGH when he was a third-year medical student and I was a third-year resident. And I had no idea who this guy was, but I knew that his spirit was so much bigger than his body. And we had all of these discussions about social justice, and he challenged me in many ways to, because of my own background. He grew up in North Carolina. I grew up about 100 miles north. He challenged me to get back to my roots. And I talked a little bit about my roots last night. I won't be doing that today. Some of those things that you can see online, but in essence, my mother was a seamstress in a sock factory, and my father was a postman, and they did something monumental that changed the course of history within the state of Virginia. And as I mentioned last night, it resulted in Martin Luther King coming to my house when I was a 4-year-old, and it was early in his course. But Paul challenged me to think outside the laboratory. I was getting ready to go in the lab. But then in 2006, I sat with him in Philadelphia, getting ready to give the general surgery boards, and he said this in effect, that as I was talking about my lab and the molecular work that I was doing, he was talking about the work that he had done in Haiti. I recognized, and in Africa, that the more molecular we become, in many ways, we are missing that big picture. So I talk about this concept of getting to the balcony or the penthouse. And I'm a surgeon. I'm a former molecular biologist. I love being with my hands in the patient or my pipette in the right place. I wasn't often in the right place. That's why the technicians did it better. But we have to understand the biosocial factors that underpin what we do as surgeons. So I'd like to ask you, as surgeons here at the Children's Hospital and the surgeons who might be at the university watching, who are we as surgeons at this time, 2022? What is our identity? And rhetorically, I'd like to know, do we have any social responsibility? Not just physicians, but do we as surgeons have social responsibility? And so I might offer that is our professional duty to improve the health of our society. And these are the myriad ways that we might approach it. And each of these might be unique to us. And there are some of us who would say, this is not my lane. I don't want to do this. And in fact, there are many groups that say that we should steadfastly resist any tendency toward moving into this area, because this will dilute the quality of our work, and that we don't have the cognitive bandwidth in order to do great surgery and to do things in the community. I challenge this though, and I challenge this. I mean, whether you're red or blue, Republican, Democrat, conservative, or progressive, we have a responsibility to have our voices known. We have a responsibility, and in not any kind of overly patriotic way, but as Americans, to be engaged in the things that make a difference. So back onto this concept of the surgeon as advocate. Obviously, I feel very strongly about this, and I feel that not everyone has to pursue advocacy, but I think particularly for those of you who are coming along in training, there are opportunities for you to see your impact over the course of your career in a different way. When I was in the lab with Patricia Donahoe, she often talked about impact factor, IF, where we were going to submit work, science, nature, PNAS. And I think, though, outside of the basic science realm, we still should be thinking about our impact factor. But it requires us as surgeons to extend outside of our comfort zone. This guy, Rudolf Virchow, the father of modern pathology, ironically, a great scientist, a great describer of the human condition, Virchow's known, wrote in the mid-1800s, when he had a newspaper that talked about issues of social medicine, he felt that physicians were the natural advocates of the poor. And I found this incredibly intriguing, because I believe the same thing. especially, I believe, surgeons are the the natural advocates for those who are the least, the lost, and the left behind. What is advocacy? I won't read this, but you guys understand this well. It's our action and along the issues that are important. And it doesn't require you to be an activist that is yelling and screaming and shouting. I think it just really requires that you consider how you show up in the hospital, how you show up in the community, what committees, how you show up at the ACS or at APSA or SUS. There are opportunities to do advocacy, even if you do basic science, and even in the realm of ensuring that there's access. And I have to say, there are those of you who do things internationally, like my colleague who's in Chad. These are various forms of advocacy, although they're outside the country, but they're very important. There has been a refrain within our national dialogue that we as physicians, and particularly we as surgeons, should stay in our lane. And I would say, I don't think people know what our lane is. And so this young surgeon, Heather Lieb, who is in the pipeline to be a pediatric surgeon, wrote this paper that was published earlier this year in the American Journal of Surgery, which I really liked. And she examined the surgeon's role for social justice. She looked across three groups, three academic institutions. She had about a 41% response rate, and I've taken the data out, but she found that particularly women surgeons, women faculty, and women residents, 86% have participated in advocacy, as opposed to the male surgeons, only about 53%. And what she also found, that the reason people did not participate, those who didn't, were issues, concerns of their personal choice. They were concerned about the professionalism of taking a stance, and they were concerned that it would interfere with their relationships with patients. All of these, I think, are incredibly important. But what was exciting about this paper and the data that I took out is that particularly younger surgeons, and particularly female surgeons, were really, if you will, geeked about the opportunity to work in this realm. I'm not sure if any of you know who this is. This surgeon has been my mentee and my protege for about 21 years now. And my wife would yell at me during the pandemic because we would spend at least 2 to 3 hours a week as she was planning her approach to the pandemic. Ayla Stanford, one of my trainees, former trainees, decided that she'd leave her pediatric practice, and as you can see there, go stick a swab up people's noses in Philadelphia. She made a monumental change in the outcome of COVID in Philadelphia. So much so that she was frequently on CNN and MSNBC. Anthony Fauci gave an incredible introduction to her as she was nominated as one of the CNN heroes. She was one of the Forbes under 50. And so this is how you, as a surgeon, regardless of what you do, can see a problem, look at what your talents are. She actually, in the first wave, personally with her team, Black Doctors Consortium, vaccinated more people against COVID in Philadelphia than any of the major healthcare systems. And she's now Undersecretary for Health. Peter Masiakos, a good friend, a confidant in Boston, similar things, working in the realm of head injury to ensure that people were not using ATVs without helmets, working in the realm of violence. So I think that, back to the point, that surgeons not only can be advocates, but they also can be great leaders. And that Dr. Schulich, as you're planning the next iteration of training for this bright talent that you have here in the room, as well as the talent that is, I'm sorry, Fritz, I was calling you, I butt dialed you by FaceTime. So you were just looking in my pocket. I was wondering why your phone was ringing and my phone was ringing. Not a very good view in there. But I think that this concept of considering, as we have people go in the lab, as I did for 2 years, as we have people do international rotations, I would think that we should think about developing a curriculum that helps promote the development of socially responsible surgeons. As Tracy Decker, Associate Professor of Surgery at BU Medical Center did, she pioneered her program in 2014. She is an incredibly dynamic person, trauma surgeon, and she has a whole host of people who are her proteges who are kind of moving across the country to do this. UC Davis, Diana Farmer has a program. And what this program focuses on in training as a parallel track to all the other things that we must train is that it promotes advocacy, education, research, and service. These are the 4 pillars that make up the framework of the SRS program. And you can see in detail what they do. The service is a service learning component, and this has been incredibly popular at BU. And this is the curriculum that is incorporated into the surgery program that focuses on these areas. I'm not going to go into this so much, but I think just as much as we focus on the academic surgeon being a basic scientist, I think that we should begin to think about focusing on the academic surgeon as being a social scientist, one that's not just doing, one that's collecting data and going deep. So I've run through that quickly, and I'd like to run through this last 15 minutes fairly quickly. Never in my life, as a surgeon, did I want to do trauma. One of the things I liked about pediatric surgery when I started in 1992 in Cincinnati is that trauma was splitting injuries from bike and automobile accidents. Penetrating injury, when I was at the MGH and I was the super chief, I did enough of, it was fine. You felt like you were a hero, except when the person came back a couple months later, dead or shot again. But I mentioned that, you know, like many of us in this Hallstadian tradition, I had an opportunity to be a leader, a chief. Wow, a chief, you know, little boy from Lynchburg, Virginia, chief of surgery at a major children's hospital. But when I got to Cleveland, I was baptized in a cauldron of violence, not directly, but as both a voyeur and a bystander. And I recognized that violence is a public health issue. And you must be living under a rock if you've not recognized the same thing in our country. And in fact, in places like Cleveland, the pandemic has been awful relative to the dramatic increase in gun violence. So our children's hospital sees about half of the violence within the city. When I arrived in 2007, we saw about 30, 35 gunshot wounds a year. We moved to 70 a year. During the pandemic, we moved to 80 a year. And as of June of this year, and this is children ages 0 to 15, we've seen 80 by June of this year. And it's just unconscionable for me to imagine that that's the case. And in 2012, gun violence in children 0 to 18 caused more deaths than from 2 to 18 caused more deaths than all the other causes put together in the city of Cleveland, Cuyahoga County, that is. And so we had much work to do. So the increase in violence is up 47% and over the time. And what I've recognized in a place like Cleveland, where we had a big COVID surge and we had a big violence surge, that this was a syndemic. And what a syndemic is, a term coined in the 1990s, is when 2 epidemics occur synergistically, and the impact of them is greater than the impact of either pandemic separately. And so you guys are familiar with this New England Journal of Medicine article that came out earlier this year that showed that in 2019, for the first time, that firearm-related injury surpassed motor vehicles. I mean, this is a dramatic slide. That the injury prevention efforts, for those of you who do trauma, have been remarkable to decrease people wearing their seatbelts, bike accidents, people wearing their heads. But as I get it, I grew up with a gun in the house. I don't own a gun. We're not doing so well with firearm safety in children. So I mentioned to you I took this dream job in Cleveland in 2007. And distressingly for me, my very first patient was a 14-year-old boy who was shot in the leg. He came in dead and he left dead. We did everything we could. And the reason why it became so compelling to me, because he looked like my oldest son, who was 1 year younger. And when I spoke with his mother, I just can remember her running around the room in circles, yelling and screaming. He was a great student. He was going to his aunt's house, taking his video machine with him. And there are parts of Cleveland that if you don't have something they call a hood pass, then you're going to be dead. And a hood pass gives you permission to go in a part of Cleveland that is not your native area. You're not a part of the gang. And so he died. And when I had looked at the city that I came to, and I knew that I wanted to run to the fire by coming to Cleveland, this is the city. So the important things, highest infant mortality of any city in the United States. It has the highest child poverty rate of any city in the United States. Lots of other things, and the highest child suicide rate in the public schools within the city. So you might ask, why would you want to go there? Well, I think if you want to make a difference, if you want to cure cancer, you don't really look at completely stage 1 disease to do your research. You want to look at metastatic disease and figure out how you can begin to make a difference, to understand. And this is his mother showed up at my endowed chair ceremony and gave powerful words, but this is Brandon Marshall. This is 15 years later, and his mother still keeps a ribbon on the tree in front of the house, thinking that her son will come in. It tells you a lot about mothers. It tells you a lot about parents and the loss of a child. And so, Dr. Schulich, as much as I try to get my way back to formal academic medicine, to reconstruct my lab in Cleveland, I just kept getting pulled back by all the social problems that existed within my patient population. I kept seeing 40-year-old grandmothers with AV fistulas, with terminal kidney failure, and I recognized that where our kids were coming from prematurely, where our kids were being shot, were all the same areas. And I recognized that the roots of violence that I was seeing existed much below the surface. And that in order for me to make a difference in health and healthcare in Cleveland, I needed to do what Frank Lloyd Wright commanded of his young architects. He said that before you build a beautiful place, you have to come out to Arizona or to his other place in Wisconsin and put your hands in the soil and let the soil run through your fingers so that you understand the terroir. For those of us who collect wine, as you know, it's the sun, the soil and the water and the temperature and all those things that determine who a person or who the grape or the fruit is going to be. Brian Stevenson, someone who I've long admired, and those of you who are at APSA, the biggest coup that I've had in my life is getting him for $75,000 to $100,000 speaker fee to speak at APSA for only $5,000. And he often talks about getting close to people, and that's that putting your hand in the soil. So when Brandon Marshall came in, I was angered. I mean, it was moral injury for me. I rushed into the president of the Children's Hospital, a man by the name of Michael Farrell, who used to be the COO here, great friend and mentor, and asked him, what are we going to do about this here? And he looked at me like every great leader does. And he said, Ed, what are you going to do? And so it gave me pause. I came back a week later. I said, can you set up a meeting with the chief of police and the mayor of the city? He did. And the chief of the police, the mayor of the city, and I set up this program called Operation Focus. It was a hard love thing, modeled after Ceasefire in Boston. We brought all these gangbangers that were kids. We read them the riot act. We had mothers who had lost children. We had people who'd been in prison, who had abused, physically, sexually abused young people. We had them talk. And lo and behold, what happened? We cut the murder rate to the lowest it has been in the history of Cleveland in 2010. We started in 2008, and by 2010, it was the lowest ever. We parlayed this into a $2 million grant from the feds, and in fact, Eric Holder came to Cleveland to anoint our program. Sitting next to him is my friend Steve Dettelbach, who's now the director of alcohol, tobacco, and firearms. But he was U.S. Attorney General of Northern Ohio at the time. We worked together to create this award and program. But lo and behold, when the money ran out, the violence rate went up. But in that time, I'd had an opportunity to spend time in crack houses, street corners, the juvenile detention center, churches and rec centers, in order to, if you will, get to understand the community and the kids, many of whom, all of whom, looked like me 50 years earlier. And as I spoke with them, many of them talked about what they described as life. And life for them was living in fear every day. Something I really couldn't imagine. And when I met some of the younger kids, when I went to the elementary school, I recognized that in some cities in this country, it is as though there are no children there. That childhood is blurred. Many of them have seen things that I hope I never see. They have witnessed violence in the home and in their community, and it changes their perspective, such that by the time we see them in the PACU preoperatively or in our clinics, we recognize that there are a whole host of social determinants that have caused them to tumble down society stairs. And we kind of ask them what's happened to them, but it's really hard to begin to undo the impact of the changes that have occurred in their brain and development. You may be familiar with this Felitti and Onda study, which I think is one of the most important studies in medicine to be published in the last 25 years. And this is their study that looks at adverse childhood experiences. And you're familiar with it, I'm sure. They looked at a group of middle to upper middle class people, 17,000 in Kaiser Permanente's health plan, and they evaluated whether they had any adversity within their lives. And they identified adversity as household dysfunction in those three categories of abuse, neglect, and household challenges. 2/3 had at least one event, and there were a number who had 2 events. And so if you look at this very busy slide, what it tells you is that if you have a lot of adversity in your childhood, then if you have 6 or more, you have a 20-year differential in your years lost. And in fact, if you look at Rainbow, where Rainbow is positioned, its neighborhood, the average life expectancy, taking out crime, is 64 years. 6 miles away, the average life expectancy, still within Cleveland, is 88 years. And the difference in adversity that has been experienced within this neighborhood runs in this range of 4 to 6. And you can look at the upper component: lung cancer, drug abuse, premature sexuality, all those things. And this childhood adversity has such tremendous impact on the outcomes. And so therefore, I recognized that violence was a major driver of health outcomes in Cleveland, the ones I've mentioned to you: death, disability, premature death, disability, disease, and despair. And that if we could think of a program that might effectively address violence, that we might begin to change these health outcomes. The challenge that I noticed, so on one side, as surgeon-in-chief, I go to really fancy places and give really nice talks about things that we're doing, not violence, to get donor money. But I'm not able to talk about violence because violence turns our donors off. And I recognize that there is a tremendous sense of apathy and inaction that exists within our community, but also that exists within us as practitioners. And this is the essence of what structural violence is that it is this inability for us to look at the problems that exist and to think of creative solutions. I see a number of you that are young here. Are you familiar with the Serial podcast, anyone? Yeah. So this is my relationship with the Serial podcast. 2015, 7 years ago, within 5 days, I had 5 kids shot, 4 of them you see here. But the one that stood out, killed, 4 died, One, the little boy is alive and graduating high school this year. But this cherub that you see here was the subject of the Serial Podcast Season 3. And I can tell you, this is the size of her heart. I know it because for 20 minutes, I tried to squeeze life back into it. And she was sitting in the car waiting for her mother to get candles for her father's birthday. And two warring gangs, 15-year-olds shooting across the street, shot, and she was injured. And it was a second moral injury for me that really pushed me over the top. It was a call to action. And I'm going to just run through the program that we developed in the 5 minutes that I have. So we first looked at our data. And so what this data shows is the violent injuries that we saw between 2016 and 2017, mostly focusing on the gunshots. We saw 71 gunshot wounds. We saw about 200 total violent episodes during that period. 30% of our gunshot wounds would be back within a year. Now, this is kids from the ages of 6 to 15. We had a 7-year-old shot twice. Not only that, 30% of the kids would come back with a suicide attempt. So we recognized that there was intense issues that were occurring. So we developed a collaboration with the School of Urban Poverty, which is a part of the school akin to a school of public health, and they have one of the largest big data banks in the country. Since 1989, they have records on every child born in Cuyahoga County, urban or suburban, and 650 plus children now, and now over 250 million records in the system across 35 domains that you can see here. So they know when the kids had their first pediatrician's visit. They know how many days of school, but more importantly, they know their involvement with social service agencies. We collaborated with them. We work with our emergency department and our own trauma registry. And I don't have time to go through the data as I list here, but the important thing that we did is we identified that there were 450 children who were victims of violence. One category were those who were assaulted, another category of those who were shot. And we compared them to an age-matched, neighborhood-matched control of 20,000 students in the Cleveland public school system. And so again, we wanted to get a picture of who they were. And these are numbers. And essentially what we found is that early adversity and trauma determines the risk for a child to be beat up or shot. Those who were shot had greater childhood adversity. They were more likely to be premature. They were more likely to be involved in the welfare system. However, those who were assaulted were the same. It mostly came down, our data came down to issues of food insecurity and maternal stress. And what we recognized that the concept of treating them and treating them was not the way, that we needed to create an ecosystem of care. Margaret Mead said that the first evidence of civilization was a healed femur. Curious, huh? So why? Well, you can see here a broken femur is evidence that someone stayed with that person until they recovered and that they could walk. And I think that for those of us as surgeons, that this concept of staying with people who are fragile and broken until they're healed is a core component of who we should be. Accompagnateurs. Now, I'm sorry, my French is not good, but it is one who goes along with. So we developed this program. We focused not on the vector, but we began to focus on the victim. Not about guns, but about who's injured. And we looked at these kids that we saw who were growing up in these chaotic communities and who became injured and how fragile they were. And we decided, and I came to understand before we decided what we were going to do, I came to really understand that hurt people hurt people. And my good friend, John Rich, who I trained at the NGH with, who's a major leader in this, challenges us to change the language of violence so that we see victims of violence not as people who are morally deficient, but people who are injured and who are healing despite their circumstances. It's kind of hard for me to get my arms around this until I got deep into seeing many of these kids who seemed like they were me at another age. And once I saw myself as a trauma surgeon and as a healer, I recognized that if hurt people, then we're healers. So healed people can heal people. And so I stopped thinking about what we were doing downstream, taking the kids who were shot, fixing them up, and how could we go upstream to move from individual impact to community impact? How could I invest my time, my talents, and treasures beyond the hospital setting in order to create a program that would allow us to invest in these kids who are at risk? So we use the term anti-fragility. It was a term I coined from a book that I'd read by Nassim Taleb in the early 2000s. And this concept that my grandmother would tell me that the world breaks everyone, but afterwards, some are stronger in the broken places. And how could we make kids stronger in the broken places? I took all of my moleskins, which were my lab notebooks from the experience I had going into the streets, not dressed like this, meeting gangbangers, and we created a system of human-centered design. We used our empathy to define the problem. We created ideas. We built a prototype and we tested it. This is what anti-fragile is. So fragile, you drop it, you break it, it shatters. Robust, it resists being broken. Anti-fragile is something that once it's broken, it is stronger after being broken, like DNA. And the concept of kintsugi, I'm a kid who always wanted to be a potter, and kintsugi is this Japanese artwork that there's gold placed between the interstices of the fragment that makes it more valuable than it was before. These are the core values of our program: community, equity, prevention, opportunity, and care. Our specific aims, as you see here, this is our summary. We're a hospital-based violence intervention program, 12-month holistic person-centered model. And this is the way that we provide the care. We meet patients at the bedside of what I call the teachable moment. That's when the most macho boy usually has a come to his mortality moment, if you will. And we talk to them about our program. We try to engage them and their parents. And we recognize that healthcare occurs in the hospital, but health occurs in the community. So our team, my team of social workers, goes to his home, for a girl, their home, within 48 hours to engage them in our program. Only 30% agree, but we're able to engage them. I love this idea. I developed this idea, and this is our now governor, Michael DeWine. He came to Cleveland as Attorney General to look at the problem of gun violence in the inner city. And I wanted to speak with Mr. DeWine and present our program to him. And he kept telling me, "Doctor, I have no more time for you." And I kept walking and talking. The security people were coming, and he said, "Doctor, I said I have no more time for you." 45 minutes later, we were still talking. He said, "This is a great idea. If you get it on paper, I'll fund it." That was $2.6 million ago. And we got our initial funding of nearly $700,000. So it tells you the importance of being persistent with your idea. I'm not going to show you our program in detail, but we developed it over a 2-year period of time with our funding. The virus hurt us a bit. We collaborate. We want to create a trauma-informed hospital. We've developed a seminar and trained now 4 cohorts of 25 medical students. And you can see the talented group of people who've come to our seminar to participate in the process, and we've done research. This has resulted this year in a trip to the White House to meet the president and to meet some other incredible people and some work within our community. So when you're asked to stay in your lane, I would challenge you that humanity is our highway, and there are multiple lanes to that horizon: basic science, clinical work. And so I think it is important for all of us, particularly the leaders, those of us who are senior, to lean in, to innovate, to educate, to collaborate, to build, and to establish an environment that allows for us to take the best and brightest that we bring into our program and cultivate them. So as I close, Dr. Schulich, as you are familiar with this picture, producing surgeons of the highest type will stimulate the finest youth of their country to study surgery. And I think that as we approach this social determinants and advocacy, we will attract more, as we're seeing, and to devote their energies and their lives to raising the standards of surgical science. And I think advocacy is a part of that. And so, as LD Britt says, we have an unbreakable contract with society. And I think that we as surgeons have been and will be the leaders for generations. So as we move forward, let's not just fight against disease, but fight for justice. I thank you all for allowing me to go over and to have this kind of crazy slideshow. I appreciate this opportunity to come to Denver and spend time with you.
Thank you, Dr. Barksdale. That was wonderful, and it gives us some time to consider subject matter I would suggest we spend far too little time on. And you've shown us some very concrete things you've done in your own community. I would open it up to questions. Dr. Schulich.
Dr. Barksdale,
Thank you.
congratulations on a wonderful presentation. And I think I have just seen a much more eloquent discussion of some of the things I think about through a cancer lens, right? The four main strategies against cancer are prevention, early detection, great care, and make sure you have good access for cancer care for everyone.
Right.
We focus on number 3 at academic hospitals. We're always perfecting the operation, better chemotherapy, immunotherapy. But if we put our money into the first 2, we go so much farther. And if society perfected number 4, we would do much better. Yet at these institutions we're at, we focus on making the cure even better, better operations, better medicines, and I think we need to rethink things.
Yeah. And I think we can rethink them. The way I think we rethink them is through what I call boundary spanning leadership. That is collaborating broadly with communities, with business, in order to get the outcomes that we aimed for. So we can still be in our somewhat silo, but we're open. We have open windows in which we are, or doors in which we're allowing others to come in. Any other questions?
If I can ask Dr. Barksdale, is the program director here, how have, and this might have been in some of those slides that went through quickly at the end, but how has this work been integrated into your training program?
Yeah.
there?
So within to our surgery training program, we're still in the nascent stages. And I think what often happens is that, we're a high volume trauma place, but I think that our leadership, we're only a recent trauma center, about 5 to 6 years. I think there's some anxiety about embracing too much in the realm of trauma, because it then takes away from, the donors who are seeing this more as a place that's attracting trauma than advanced cancer surgery and otherwise. What's happening to us, though, is that the medical students are pushing us to this work. We have so many medical student volunteers, and we've seen an uptick in the number of medical students who want to pursue surgery, but to pursue surgery from a social justice perspective. And so I think that, you have to be patient, and it's kind of like how we got the funding. You keep beating the drum, and the people who feel that rhythm will migrate toward you, and those who hear it and don't resonate with it will just see it as noise. But I think that within any program, academic program for surgery, having a wide variety of tracks that people can pursue allows you, again, to attract the best and the brightest. That's our goal in academia, is to be a magnet for talent. Thank you all.
Thanks
Appreciate
again.
your attention. Yeah.
Dr. Barksdale, we do have a little bag of University of Colorado swag, so to speak. You might have noticed some of us are all wearing the same ties this morning, and you are going to be lucky enough to have one yourself in here.
Thank you.
I think that'll go well in Cleveland as well as
Yeah.
it would here, right?
Well, does anyone know why this won't go well in Cleveland? Anyone from Northeast Ohio? Well, these are the colors of the University of Michigan.
Yeah, similar.
And in Ohio, blue and orange is.
Understood. And then the anatomy of, or the kind of history of the Department of Surgery here, which you're already somewhat very familiar with.
Yeah.
Thank you again for your time with us. And we're going to be spending some more time this morning as well. So
Very good.
thanks, everybody.